Hi, this is Dr. Fox, and let's talk about facial nerve or Bell's palsy. In this video, we'll discuss facial nerve or Bell's palsy and how one might distinguish between it and a cerebrovascular accident. So first of all, let's tip our caps to the prominent Scottish surgeon Sir Charles Bell, who discovered this condition and for whom this diagnosis is named. Dr. Bell was a very prominent neuroanatomist as well. He was the individual who discovered that there were both sensory and motor fibers within the brain, and also discovered the long thoracic nerve, among many other accomplishments. So we try to stay away from eponyms in the course because they tend to be very problematic and not very equitable with respect to representation. But from time to time, there are eponyms that you will most frequently hear in conjunction with particular regions or diagnoses. And so when that's the case, we do tend to incorporate them into the curriculum. So Bell's palsy has a series of symptoms, some very, very common and diagnostic, and others quite rare, but nevertheless still diagnostic. The most common symptom of Bell's palsy is an ipsilateral paralysis or paresis of the facial muscles. So let's dissect what that means. So ipsilateral means on the same side of the body, same side as presumably the lesion to the facial nerve. We can contrast that with contralateral, which means on the opposite side of the body. A paralysis is the complete loss of muscle function, whereas paresis is a weakening of the muscle. So with a paralysis, you might lose total innervation to the muscle, whereas with a paresis, you might lose a significant amount of fibers serving many motor units, but you might not lose all control of that muscle. Now, the underlying cause is a lesion or damage to the facial nerve. For this in particular, the motor trunk of the facial nerve. Recall that that is going to exit the stylomastoid foramen, and so anything beyond that stylomastoid foramen, so outside of its bony pathway, will make it vulnerable to damage. So less common symptoms of Bell's palsy include ipsilateral hyposalivation, so less than typical salivation, and this will be complements of denervation of the submandibular and sublingual glands. Both of those are served by the submandibular ganglion, the preganglionic fibers of which are a branch of the facial nerve within that facial canal of the temporal bone called the chorda tympani. The chorda tympani, if you recall, also is conducting special sensory fibers back from the anterior tongue. So ipsilateral ageusia of the anterior tongue will also be a symptom, albeit not as common as ipsilateral facial muscle paralysis. An even more rare symptom is ipsilateral hyperacusis. Hyperacusis means that sounds sound louder on that side. And that's because we have denervated the stapedius muscle. Recall the intermediate branch of the facial nerve in the facial canal is the nerve to the stapedius muscle, and without that stimulation, any loud sounds can't be dampened by the stapedius muscle. And then finally, ipsilateral hypolacrimation. So hypo, less than typical tear formation, because we're losing the function of the greater petrosal nerve, which is supplying the preganglionic parasympathetic fibers to the pterygopalatine ganglia. So looking over here at our very good friend or patient, or potentially both, what we can see, if we just make that a little more distinct, on one side of the face, so unilateral, without making any presumptions as to the cause, we see unilateral facial paralysis. And we can see facial paralysis because there aren't the telltale signs of wrinkles of the skin, which we would see if the facial muscles are working. We can see that the eye, the palpebral fissure is nice and patent. The modiolus is holding the corner of the mouth up and in a neutral position, whereas when we begin to lose stimulation of these muscles, we don't see wrinkles in the forehead. The eyes tend to begin to droop. The corner of the mouth begins to droop. And there's just a general loss of facial tone throughout. So we can see that on this individual here. So again, let's kind of draw our line here. This individual was instructed to smile. You can see, they've got wrinkles. They've got some skin creases there. The corner of their mouth is being pulled up. Whereas on this side, complete lack of wrinkles. The eyelid looks a little droopy, but we don't see the smile lines there. The corner of the mouth, when instructed to smile, does not go up. So it's indicative of an underlying problem. So generally, there are very many things on the list of the differential diagnoses for what can happen to the facial nerve. So an infection by the herpes simplex virus can knock out function of the facial nerve. Any sort of swelling, be it from injury or cold exposure, hormonal fluctuations as they impact the vasculature from pregnancy, etc., can be problematic. If a dental health provider in the course of performing an inferior alveolar nerve block goes a little too posterior from their target, they might inject anesthetic into the substance of the parotid gland, which then could interfere with action potentials along the facial nerve as it moves through the parotid gland. And oftentimes, we just simply don't know. So it's an idiopathic cause. And generally, this is unilateral, but bilateral bells is possible, but it is just exceedingly, exceedingly rare. Another diagnosis on the list on the differential is a cerebrovascular accident, CVA for short, colloquially a stroke. The major way of differentiating if it is Bell's palsy is that the facial muscles of the entire face are paralyzed or weakened, whereas with a cerebrovascular accident, it's the facial muscles of the lower face, and there could be other symptoms as well. So if it is Bell's palsy, it will be an ipsilateral effect, but you won't know that. If it is a cerebrovascular accident, it will be a contralateral effect. And so let's take a look at why. So let's start with with Bell's. Let's assume that that this is the condition. Well, recall that motor root is exiting the stylomastoid foramen and breaking up into the temporofacial divisions and cervicofacial divisions out to serve the facial muscles. So, coming back here, if we impinge on that somehow, we are losing, over the course of this, all facial muscle ability to contract, or it will be weakened equally among all of the different muscles of the face. So let's go back and erase this, and go back and pull up green. Let's take a look at how a cerebrovascular accident or a stroke could affect facial muscles, and let's see how these pathways work. So the motor regions of the cortex are located in the cerebrum, and we can see, let's just start with those on the right side. So the upper motor neurons are going to begin that serve the right facial muscles on the left cerebrum. They're going to go down, and they're going to decussate or intersect in the medulla. So notice here, and let me erase this so that we can see it a little more clearly. Most of the orange is heading over here to the right side of the brainstem. Some of the orange, albeit less, will be on the left side. And that's true for the right side. The right side will decussate as well. So you have most of the right side upper motor neurons going to the left side of the brainstem, but some of them are staying on the right. So you have a mix. So when they get down to the nucleus for the facial nerve, we'll have predominantly left side, but also some right side going through that facial canal and exiting. And so we'll have, look at the divisions. The cervicofacial division is mostly served by the contralateral, whereas the temporofacial division has a nice mixture of fibers from both. So what this means in terms of a cerebrovascular accident is that let's go back, be consistent with our colors, the cervicofacial division is going to be disproportionately affected, whereas the temporofacial division won't be as affected. So with a stroke on the left side, the facial muscles of the lower face on the right will be knocked out, but the facial muscles on the upper side of the right won't be as affected. So if an individual is asked to smile, there's going to be a difference with a cerebrovascular accident between the lower face and the upper face. You'll still have some furrowing of the brow with a cerebrovascular accident that you won't with Bell's palsy. Because with Bell's, keep in mind, you're knocking out the entire facial nerve. So you lose both temporofacial and cervicofacial divisions. So that leads us to our assessment question. So you're administering an IAN block, so that's inferior alveolar nerve block, to your patient. You're briefly pulled away, maybe for a hygiene check or a consult. You return to your patient. Your assistant was sitting next to them, chair side, and you notice unilateral loss of facial muscle tone. You're now a little worried for what might be the cause, and you maybe you joke with them a little. You tell them something funny, or maybe you just say, "Hey, can you flash me a smile?" And you notice no furrowing on their forehead. Is this an encouraging sign, or is this a terrifying sign? Well, let's work backwards. If you notice no furrowing on the forehead, that's really key here. You're also noticing a unilateral loss of facial muscle tone, which is concerning, but it's this no furrowing on the forehead. What that no furrowing on the forehead means is that the temporofacial division has been knocked out. There's no, obviously, signs of muscle function throughout the remainder of the face, so we can then also assume that the cervicofacial division is out, but it's really that loss of the temporal-facial division, which suggests that this is Bell's palsy, that you probably injected, septocaine or lidocaine into the substance of the parotid gland, and while this is your fault, it is not an emergency. So that is an encouraging sign. So B is the correct answer. If you had asked them to smile and you noticed that the temporofacial muscles were working, but the cervicofacial muscles were not working, this would be your sign to call 911. That's an indication that they might be having a stroke. You'll probably want to ask them to raise both arms, to smile again, to repeat an easy sentence back to you to see if there are any other indications of a cerebrovascular accident, but you will have called 911 and they will rush this person to the hospital for treatment. So thank you so much for your time here, and I look forward to